Yeah.
Okay, so good morning. I think this is broadcasted right now, right? To all attendee. So good morning, everyone. Good morning, Prof. Tati, Prof. Su, Dr. Diani, Prof. Bambang, Dr. Parintosa, and Dr. Rudiyo. Thank you very much for joining today's IROS CME webinar. So I'm Handoko as a moderator for today's event. Today's event, we will have a expert, Prof. Su, which will talk about Reirradiation and Post-Reconstructive Radiotherapy in head and neck cancer. And before we start, there are a few notes for all the participants. So to enable this event to run smoothly and to avoid bandwidth burden, we appreciate very much if you could kindly turn off your camera and mute yourself when you are not speaking. You may use the raise hand feature at the bottom of this Zoom before speaking, and feel free to comment or ask questions in the Q&A column anytime during the meeting. We will address that questions at the end of the speech. And first, would like to hear the opening speech from our IROS Indonesian Radiation Oncology Society President, Prof. Tati. I think most of you here already know Prof. Tati. Prof. Tati supports very much this event, this continual event, and please, Prof. Tati, give the opening speech.
Yeah. Thank you very much, Handoko. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen, my fellow colleague in Indonesia and surroundings. It's always a pleasure to welcome everyone at our IROS webinar, especially at our keynote series where we are joined by a respected global expert in our field. Today, please join me in welcoming Professor Su Yom from the University of California, San Francisco. She is a well-known expert in the field of radiation oncology, especially in head and neck cancer, among others. Thank you for your support, Professor Su. It's a truly honor that you are here with us today. If I may introduce a bit about our situation to Professor Su and others who may be not familiar yet, Indonesia is an archipelago with more than 17,000 islands and population of 270 million. Our cancer incidence is around 390,000. Our main challenges included that 70% of our cases come in advanced or locally advanced cases. This is, of course, bring a special concern to how we deliver our radiotherapy, especially in head and neck cancer. That's why our topic today is something that is very important and very difficult, because we have to face it every often in our clinic, which is how we should do reirradiation and work with the post-reconstruction head and neck patient. Of course, this cancer treatment requires collaboration with other disciplines, as we all know every day. We have here our colleagues as our expert panel, Professor Bambang, expert from the ENT oncologist, Dr. Diani, good morning, consultant surgical oncologist and head of surgery department in our hospital, and Dr. Parintosa, consultant plastic and reconstructive surgeon, a very important man. And thank you for you. And also we have Dr. Rudiyo here from Medan, from Sumatra. Another island is not from our island. Thank you, Dr. Rudiyo. Thank you for your participation. I hope that you can share your experience and expertise to the floor. I'm really looking forward to a lively discussion session, and that we will gain much insight from Professor Su, and hope that we can work together better in the future for our patient. Please enjoy the session. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you very much, Prof. Tati, for the greeting and opening speech. So before we start, I'd like to read and introduce the complete CV of Prof. Su. So Prof. Su is the professor of radiation oncology from University of California, San Francisco. Prof. Su trained in University of Pennsylvania, and for the radiation oncology residency in MD Anderson Cancer Center. Following that, she continued in University of California, San Francisco as clinical research, and currently as a staff member and in University of California, San Francisco. Prof. Su specialized in head and neck, lung, and skin cancer. She also served as the committee in national guidelines outlining the best practice for this cancer. She also designed trials for numerous cancer sites. Currently, there are, I think, more than 10 active clinical trials under her supervision and management. And also, she is currently the chief editor of the Red Journal, and she has major interest in clinical management of head and neck, lung, skin cancer, innovations in radiation oncology, combinations of targeted therapy and immunotherapy with radiation, cell polyomavirus, radiation protection, and patient-centered decision making. She have more than 200 publications so far in numerous respective journals. So please welcome Prof. Su. Today she will talk about reirradiation and post-reconstructive radiotherapy in head and neck cancer. Please, Prof. Su, thank you very much.
Hi, and thank you so much for inviting me today. I'm very honored and excited to meet all of you and share some discussion around this very difficult topic, which I think is probably one of the most challenging ones in head and neck cancer. And more about some of those specific issues during the talk and the discussion. I'm going to just make some, short remarks here to start us out before we have our panel discussion. And I think it's really important that we go case by case and think a lot about the individual patient situation, because these cases can be very unique. The other thing I just want to say before starting is that I always enjoy speaking to an international audience, and particularly in my role as the editor at the Red Journal, we have a strong responsibility as an international journal to unite the worldwide community of radiation oncology. I feel this is very, very important because we learn from each other this way, and we do the best research this way, and we can share the most with the most patients this way. So very much we take very seriously the word in our title, which is International Journal of Radiation Oncology, Biology and Physics, because we are really trying to unite the community all around the globe. And that's increasingly important in a time when those things are more and more difficult. So thank you very much for being here. Let me see if we can share the slides. Are you going to put my slides there, or should I share again?
If you
Dr.
can share.
Handoko, do I share now? Okay.
Yes, please.
Let me see if this
share.
will continue. Okay.
Yes,
how is this looking? Okay, very good. So we're going to talk about reirradiation. And I think a very related topic is reconstruction, because often these two things are going together, although I'll address them kind of as separate topics. But be aware that often in the case of reirradiation, the way that the patient will be reconstructed and the condition of the tissues is actually a very important consideration here. These are my disclosures because, as I understand, you are offering some medical education credit today. So we're required to disclose these things. For the past 5 years, I've had research contracts which are paid to my institution, not to me, for various clinical trials. I also received some research grants from state and national authority, as well as NRG Oncology, where I am the chair of the Head and Neck Committee. And then to me personally, I received royalties from some books and chapters that I edited, as well as a publication-related honoraria for my role at the Red Journal, both from Astra and Elsevier. There are 3 most common scenarios for reirradiation, and one which is very controversial. So the three common scenarios are that in the case where you can perform a salvage surgery for a recurrence, you will have some features that mandate reirradiation. The second form of reirradiation is when you cannot do a curative intent resection and the patient has been radiated before for some reason, and you have either a second primary or recurrent tumor. That tumor is not able to be resected and you must reirradiate in the native condition. And then finally, of course, there's palliation, which is a component of all practices of radiation oncology. Our census is around 50% of our treatments are essentially palliative. And then I will just mention that there is this controversial emerging indication, which is that in the case of recurrent metastatic disease, when the patient is on systemic therapy and has what is termed by the ESTRO-EORTC as oligoprogression, meaning that the patient has progressed on this therapy, you may want to reirradiate to prolong their time that they can remain successfully on that form of therapy. And so this is a very controversial indication, and there is no data right now to support that in head and neck cancer, but it has been shown to be effective in other diseases such as lung cancer. So to understand where we are with reirradiation, we have to understand what has gone before. And there's very, very limited data on the outcomes of reirradiation in the prospective setting. There are really only two major studies, and these are foundational to the literature on reirradiation, which both came out of the Radiation Therapy Oncology Group studies back in the 1990s and 2000s, so quite old. RTOG 9610 was a study where they were giving, as you see, some chemotherapy that may not be so familiar to you anymore, 5-FU and hydroxyurea. This is somewhat based on the University of Chicago experience with hydroxyurea. But anyway, 60 gray, which was given in BID fractionation, this wasn't an attempt to lower the late side effects of the radiation by hyperfractionation. And in this study, what they were trying to establish was essentially the outcomes when you combine chemotherapy with radiation therapy. The median survival was 8 months, and the 2-year overall survival was pretty dismal at 17%. The grade 3 and higher acute toxicities were very high. If you look at this, the overall grade 3 toxicity rate was over 60%. The non-hematologic, which is what's often important to the radiation oncologist, essentially 50%. And hematologic toxicities, 1/3 of the patients. And there were notably 6 deaths in this study within 90 days, 2 from hemorrhage, and then 4 from the effects of chemotherapy. So this is not very inspiring, but I think it is realistic, because in the setting of gross disease where you're reirradiating with combined chemotherapy and radiation, it has to be understood at the beginning that the 2-year survival will probably be on the order of somewhere between 15 to 30%. So why do I say 30%? Because in RTOG 9911, which was a follow-up study about 10 years later, we found that we could give more effective chemotherapy with cisplatin and paclitaxel here. And the RT was again based on the same BID fractionation schedule. Keep in mind that even though this was hyperfractionated radiation, the total dose was 60 gray. And so it is not a very, very aggressive radiation. But in any case, the median survival here was slightly better with this more modern chemotherapy and cisplatin based, and then also with improved 3D conformal radiation therapy, got to a median survival of 12 months and the 2-year overall survival now at 25%. So when I counsel patients about reirradiation, I'm very realistic that we're really probably talking about something like 30%, right, in the modern day. And then in terms of long-term survival. Now that leaves aside all the other goals of reirradiation, which may be different, and we can talk about that more later. But again, notice that the grade 3 toxicity rate here is very high. Again, overall and non-hematologic rates now extremely high at something like 75% of patients. So you have to be aware that grade 3 toxicity is considerable when you're going to give reirradiation. And I never consent patients to this without going over the acute and the potential late side effects. And I usually give most of my patients an average of about, 75% that they will have severe toxicity, about 15% risk that they may have a fatal or other severe toxicity that requires emergency surgery. And I think it's really important to be straightforward with patients about that at the beginning for what may be a long-term survival rate of 30%. So in this study, there were again some deaths during the acute period, mostly due to toxicity from the combined effects of the chemoradiation, and then also 3 late deaths with carotid hemorrhage and oral cutaneous fistula. And to this day, carotid blowout and fistulization of wound remain some of the major concerns with reirradiation, which is where we can talk about the role of reconstruction and flap revascularization. Okay, so the update on this, however, is more promising because that data, although it was prospective and very high quality, is quite old and is mostly been questioned, especially using BID fractionation, which we aren't using in the modern day as much. And so there are 3 really important papers. I'm very proud to say that I published these when I was deputy editor at the Red Journal before my editor-in-chiefship. And it was really important to us that when the MIRI collectives began their work, that we publish all the papers together. So these were all published in a single issue of the Red Journal together as a collection. And the MIRI Collaborative was 9 institutions coming together. They were able to do a large combined cohort of several hundred patients, over 400 patients. And these were all published in 2018. And, you know, at the time that we collected these papers, I didn't realize, you know, I knew that they would be impactful. I didn't realize how impactful, because I would say that these 3 papers now define a lot of the principles that we consider to be fundamental in reirradiation. And that's important to understand. So these were retrospective studies, right? They're all a combined collection of data across multiple institutions and retrospective. So it's important to understand that this is not prospective hypothesis testing. What this is a collection of papers that documents what practice looks like in reirradiation in the modern era in the United States, okay? But that is important. And to document the outcomes of that and the principles that come out of that give us some form of guidance. Here are the general principles we can talk about from the MIRI reviews. So one thing is the timing of reirradiation. From the MIRI review, it became obvious that based on the 3 outcomes of if you read the MIRI reviews carefully, what they will do is they will classify the patients based on their time from previous radiation, as well as their level of organ dysfunction. And by doing that, by dividing into those patients that are 6 to 12 months out from their prior radiation and who have less degree of organ dysfunction, they can actually classify what the outcome is going to be in terms of survival. And it separates very nicely into those 3 classes. But one of the key principles that we can take away from the MIRI collective, as well as other supporting data, both in nasopharynx cancer and SBRT literature, is that you probably need at least 6 months interval from prior radiation therapy. And furthermore, probably the highest degree of safety would be at 12 months out from radiation therapy. A lot of that limitation is based on spinal cord recovery, because what we know is that the spinal cord does have some degree of recovery, and that is probably reaching the majority of its recovery by something like 12 months. So at least 6 months out, we feel that it's not as inhumane to reirradiate the patient. The tissues have somewhat recovered from at least the acute toxicity, and the spinal cord may have some degree of recovery. But I really will say 6 months is really my minimum. I would really prefer to see the patient at 1 year out, and most ideally, and when you're going to get any kind of reasonable outcome, is probably 2 years out. And then the target volume. So in the old RTOG studies that I showed you from the 1990s and 2000s, because we were using 3D radiation at that time, the target volumes were actually quite large, with 1 centimeter to 2 centimeter expansions. That still remains the standard to this day. Although I will say, you know, you can make exceptions to this case now because we have such improved imaging with MRI. But in general, you want to have really large margins around gross disease. And we can talk a little bit more about that, because where you're going to see the majority of your failures is really still in the gross disease region. And so it's really important not to underdose that region in any way and to make sure that the margins are wholly adequate. Current standard in this country right now, and I believe throughout the world, although it's a little controversial, is that we do not give elective treatment. So generally speaking, for reirradiation cases, we try to avoid excessive CTV elective treatment around the primary, and we try to avoid elective neck radiation. Now, there are some important and rational exceptions to this. For example, if, let's say, you had a patient who had T1 larynx cancer and never had any radiation to that part of the neck that is directly involved, then it is very reasonable to give some elective radiation if you feel that the risk is very high there. But be aware that it's a balance, and that by irradiating the elective neck, you're really increasing the potential morbidity. So in the case of a T1 larynx cancer patient who now has a second primary that needs to be reirradiated, there's two factors. Number one, the prior radiation was not morbid. And number two, there was not, a lot of tissue exposed. So in that case, maybe you can consider elective neck because the risk-benefit ratio is better. But generally speaking, because the failure remains so high in the gross disease, we don't radiate the elective neck. That may change. If we were able to increase the efficacy of reirradiation to the point that we were controlling gross disease, then I think elective neck radiation would become more important at that time. All right, and then dosage. So in the Mary Collective, what they found was that over 66 gray, those patients tended to do better with reirradiation. Now, remember, this was retrospective data, and so there's some selection bias going on, and you may see that those better prognosis patients were receiving 66 gray instead of 60. But at least in this retrospective experience, 66 gray is their recommendation, and at least 60 post-op. There is no oncologic benefit that they could find due to hyperfractionation. Now, this, again, is based on the retrospective Mary data, but I will say this. In this case, I actually really believe this finding because you would assume that the better performance status patients, the patients who have more resources, the patients who had more curable cancers probably were preferentially going to hyperfractionation. So not to see a benefit in those quote unquote better performance, better prognosis patients means that hyperfractionation probably was not producing a benefit over standard fractionation. And that's been confirmed by some retrospective reviews as well, notably from the large cancer centers like MD Anderson, MSK, Princess Margaret, where they really have not shown that hyperfractionation was able to, at least statistically, produce meaningfully positive results over standard fractionation. That being said, do I still use hyperfractionation? Yes, I do. I have a patient right now who is getting hyperfractionation with me. Why? Because he has a second primary. It is very small. He has outstanding performance status. He really wants to maintain his swallowing function. He had the means to be able to rent an apartment next door to our cancer center. He has incredible social support. So I know he will finish the entire treatment and he will not miss fractions. So that is a patient, yes, where I still give hyperfractionation with chemo. Okay, technique. So the Mary Collective found that if it was under 3 centimeters, you can consider alternative techniques such as stereotactic radiation or high-dose brachytherapy. But if the patient's tumor was over 3 centimeters, really the benefit was not seen from these kind of techniques. And they really recommend IMRT with the ability to add to the IMRT either with some chemotherapy concurrently, which is shown to be beneficial in the previous R2G studies, or potentially unique additive treatments such as hyperthermia. But the other thing to keep in mind from the Mary Collective is that there was no overall benefit seen from SBRT in these patients. Why do we give SBRT for reirradiation today? Because it's humane and it's shorter. And these patients have usually been through a lot with somewhat degraded performance status. So often SBRT is a practical consideration. And furthermore, the other thing I will say about SBRT is that in this series, again, because it's retrospective, here you have patients probably with lesser performance status, less resources, who were being sent to SBRT. So the fact that SBRT had inferior results to IMRT in the Mary Collective, to me, represents a practical consideration that those patients were being given SBRT. It does not tell me that SBRT was less effective, all right? There's no reason to think that for small lesions. So let's look at some examples. For example, here is Oh, sorry. So this paper is important. Before we go into example, this paper is very important. This is a paper from the University of Michigan. It is a classic and important paper. And when we talk about why we don't give elective radiation, this paper is one of the major rationales for that. So in this paper, they did a very close examination of patients who were reirradiated. And what they found was that 3/4 of the local regional failures in this, 3/4 of the patients had local regional failures in this series. And of those local regional failures, 96% of that local regional failure was recurring within the gross tumor area that was treated. So in other words, we still do not have decent control of reirradiating gross disease. And until we achieve that control, it seems very morbid to try to go out to the elective regional volume. And the return on radiating the elective regional volume will be low, since the majority of failures occurred local regionally, and the majority, almost all the local regional failures were within that gross tumor. And so you have the advantage by reducing the elective volume not to re-irradiate those local tissues. Like I said before, though, it's important to understand the limitations of this study, and that this was done some time ago, and that as we achieve better local regional control, the balance of benefit could change such that we may irradiate elective nodal volumes more. And furthermore, if it's not toxic to the patient to radiate that elective nodal region, you should consider it. Again, going back to the Mary collective on this dose question and the hyperfractionation question, you see here that both in terms of hyperfractionation, there was no benefit, but also the Mary collective confirmed that with elective nodal radiation in those patients who were treated with IMRT, there was also no benefit. So they reconfirmed the findings of that original Michigan study. So again, 66 gray without ENI, using IMRT with chemotherapy really produced the best outcomes in these patients. But again, you got to recall the overlay of selection bias here. And then further from the Mary collective, even though the SPRT produced generally inferior results to IMRT with chemotherapy, it's important to understand what kind of patients received SPRT and where the SPRT worked best. So obviously, when you give SPRT, you're almost never going to give elective nodal radiation or really any form of elective radiation. SPRT will be confined to the gross disease. That makes sense. We believe that. And as you can see here, SPRT also was often not given with systemic therapy. And we know that the delivery of concurrent systemic therapy adds to the survival, as was shown in the RTOG studies, the old original feasibility and comparative RTOG studies. Now, if you look here at the curve, looks pretty bad because the IMRT line is the black line and the SPRT line is the red line and the green line. And that looks kind of bad that the IMRT line is doing much better. But in those patients who had small tumors and where the SPRT could be given to higher dose, it seemed that if you could give over 35 gray with some moderate dose escalation for these small tumors, SPRT began to look more like IMRT. So for these small tumors, high dose SPRT, even without chemotherapy or without ENI, seems to be very competitive. And one thing to note was that in these smaller tumors, there was much less grade 4 and 5 toxicity, and there was no difference in late toxicity among the that comparison. And so, you know, it seems like with these small tumors, SPRT is a very reasonable thing to do. And so we do give that frequently at my institution, again, for humane purposes. And I will just add here, even though it's not in this talk, that I think it's really important that people know about the recent high-tech data that was published. The Red Journal published an entire volume called High-Tech last year, which is all about SPRT constraints. And that team, the University of Pittsburgh team, which has done the vast majority of the research on SPRT in the United States and was also part of the Mary Collective, actually published a dose analysis where they found that actually dose escalation in SPRT does show a dose effect response. And as you get above 45 or even 50 gray, the effects of the SPRT are much better on eventual outcome in terms of local control. So if possible, not only should you consider going above 35 gray, but probably the minimum for a really curative intent is 40 gray. And if you can get to 44 gray, that is probably somewhere near the top of the range where you're getting the best outcome. So we now give actually 44 gray and 5 fractions. So the issue with SBRT is that people are really concerned about the risk of carotid blowout. However, there have been some studies looking at this, again, retrospective data, relatively poor quality data, but we can make some conclusions overall. There's actually a pretty low risk of bleeding overall. And the highest risk may be with SBRT at 2 to 3 years. But the point is that you can do certain things to mitigate that risk. So if you give over 5 fractions, as opposed to 2 fractions, 3 fractions, 4 fractions, and you give it QOD, meaning every other day, the risk becomes very, very low, even in the cases where the tumor is encasing the carotid artery. Typically for SBRT, we say that it's contraindicated with more than 180 degrees of encasement of the carotid artery. However, even in cases where there has been 360-degree encasement, if you undertake these kinds of precautions, it is acceptable risk. And there's also, not a super clear relationship between dose and carotid blowout. And I think that's probably just due to the heterogeneity of the literature. We just do not have good enough analysis of that. However, of course, people are always worried about, if you go really high on the carotid artery, that there would be higher risk. And so generally speaking, the conventional wisdom at this point is just to avoid hotspots that would be anywhere near the encasement area of that carotid artery, the junction of that artery. We know that from the lung cancer data, where it's pretty clear that even though the major blood vessels are very strong and have a pretty high dose tolerance to reirradiation, you can get vascular bleed either to small arteries or to large arteries where you have hotspots. So those are kind of the same principles that we regard with carotids. If the carotid is highly encased, weakened, the wall has been infiltrated, or you put really big hotspots on there, it's just common sense based on other disease sites that would be a problem. So here are some examples now to show you of some patients of ours at UCSF where we've been giving reirradiation. This patient received chemoradiation and then 5 years later recurred from his hypopharynx cancer in the tracheoesophageal groove. And this is SBRT with cetuximab. And back in the days when we were treating like this, we were treating to 4 degree and 5 fractions QOD. But now I will just say, of course, we're giving, trying to give 44 as long as we feel that we can safely identify the carotid. Here's another example. This is a patient who had P16 oropharyngeal cancer. Now, this kind of patient, we think a lot about the P16 status. Of course, as many of you know, P16 oropharyngeal cancer patients have a really excellent prognosis, even in the recurrent setting, even in the setting where they receive salvage surgery, even in the setting where they had distant metastases, their prognosis is always better. And so for a patient like this, we probably are going to be pretty aggressive, and we probably are going to consider the balance of, the patient's performance status, their age, whether we can give concurrent systemics to try to maximize the outcome. But you also have to keep in mind that for these patients, they have a really excellent response to systemic therapy as well. But in any case, for this particular patient, he got our standard recipe, which is SBRT 40 and 5, and at that time, again, was given cetuximab. All right, now, many times these patients are being given cetuximab because they've had so much chemotherapy up to this point, and nephrotoxic chemotherapy is no longer an option. Here's another example. This is a patient with a base of tongue cancer, and this is an example of how we might use this post-op. This patient had CRT in 2011. He recurred with a second primary, so this is a different kind of situation where we're now talking about a patient who actually has really good prognosis because he is more than 2 years out. This is a second primary, not a recurrence. And he's been able to have a surgical resection and has very little functional deficit. All of those factors put this patient in basically the highest category. So he got SBRT every other day, 5 fractions as well. And in this case, it was not given with chemotherapy because it's a very minimal amount of disease. And it's not clear to us that in the post-op setting that something like this would work. Now, you could argue that if this patient were younger, such as 50, 60, maybe 70, we would consider conventional fractionation, right? But in this case, SBRT was chosen out of humane reasons due to age. All right, and then here's another SBRT example. This is a patient again who had P16 positive disease. This is the third course of radiation to the right neck. And here, as you can see, the choice was to give 40 gray in 8 fractions. And you're going to say, well, why did you guys go off your formula of 5 fractions? This is being given in 8 fractions because this is the third course of reirradiation. There's obviously concerns about brachial plexopathy, carotid, et cetera. So a more forgiving fractionation schedule would be to try 8. Now, all of this, I'm just going to say is, kind of just sort of an honest look at what we've done with SBRT at my institution. But as I said, the guidelines remain sort of unclear regarding when and how to apply SBRT. And, they're constantly evolving. For example, we're now giving 44. With SBRT, of course, all kinds of things can help you. And so we have CyberKnife delivery at UCSF. And for cases where we're trying to really avoid brain or things like optic structures, we'll often use specialized techniques such as CyberKnife, or you can use other kinds of verification. CyberKnife, I think, is honestly the best real-time and most highly pixelated treatment that we can give. So we, we'll often go to CyberKnife and maybe even more fractionated than 5 fractions when we're really in trouble. But we also use, of course, other kinds of onboard imaging to make sure our localization is good. And then we do have specialized forms of brachytherapy or hyperthermia at UCSF that will apply as needed for the different cases. And so this is a case that we treated with HDR brachytherapy. So this is a patient who had a recurrent oral cavity cancer in the floor of mouth. Thankfully, we were able to cover it with a good brachytherapy implant. And, obviously, if we can do brachytherapy, if that is a possibility, it's a really wonderful technique, especially with our inverse planning at UCSF to avoid toxicity. So we have to talk about chemotherapy considerations in the recurrent metastatic setting, because, if you look back at those RTOG traditional results, or even the Mary Collective, for the vast majority of these patients, reirradiation does not give them a very long median survival. And in some cases, the chemotherapy may be competitive. So if you can give best-in-class chemotherapy, such as Cis-5FU or the extreme, what's known as the extreme regimen, Cis-5FU cetuximab, the median overall survivals are 8 to 10 months. And that is actually competitive with palliative or even some forms of reirradiation, depending on the class of patient that you're treating. And so I think it's, it's honestly just really important to be up to date with the outcomes of chemotherapy, because they, in some cases, reirradiation will not contribute meaningfully. And of course, we now have immunotherapy that notably the PD-1 inhibition, such as pembrolizumab and nivolumab, which are approved not only for second line, but also first line now, recurrent metastatic treatment, which we'll talk about in a second. And you can see here again, the median survivals can be quite long on immunotherapy. We often talk about 10 to 12 months as kind of the expected time that we will get off of immunotherapy. Granted, their disease may not be controlled, but their survivals can be pretty long. So one important study here to talk about is the Keynote 048, and I'm sure that our panel will be able to give more light on this in more detail. But it's important to remember that in Keynote 048, this was for recurrent and metastatic disease, and about 1/4 of the patients in Keynote 048 did have recurrent disease. And so it's important to remember that this is a reasonable option, either chemotherapy with pembrolizumab or pembrolizumab alone for high CPS patients, that recurrent disease can be treated this way. And if you know the Keynote 48 study, which was very important for those patients who had a CPS that was very high, such as 20, the pembrolizumab alone is actually validated as a first-line option for those high CPS patients. And you can see that their 2-year survival is 35% or higher, which is extremely competitive with anything in the proven prospective reirradiation setting. So, again, really important to keep in mind the balance between the need for local control and the morbidity that will result from that, obtaining that local control, versus what can be done for these patients with systemic therapy alone. So here's an example where we tried, and I'm going to show you a scary story. Here's an example where we tried to re-radiate a patient. And as you can see, this patient received 66 gray and 30 fractions. He recurred only 7 months later. Very debatable if he should have received radiation again. But, you know, they really did not want to operate. They thought that the disease was relatively localized. So he received a second course of reirradiation 7 months later and noticed that there is no tissue flap in place. And this is what happened. The patient's original surgical area broke down. Now, it's important to understand, you know, in the discussion of this, that there were other contributing factors to this wound. The patient was immunosuppressed, quite ill, and also, you know, probably did not have adequate control of tumor, and furthermore, had a relatively poor wound care. And so all these different factors, infection, immunosuppression, lack of tumor control, you know, will give you this kind of outcome. He went on to progress on cytotoxic chemotherapy, which was tried subsequently. And as you can see, there was just gradual progression in this area. And of course, you know, the patient now is on pembrolizumab as a long-term option. And sort of a miracle story, the pembrolizumab actually has worked beautifully. The patient's now been on pembrolizumab for a year with occasional boluses of chemotherapy, and he actually remains able to function and work full time, although of course the fistula remains a wound control issue. So just an example of, you know, various attempts to try to help a patient achieve local regional control and what different therapies may or may not achieve, and some of the cautionary tales about it. So there's an ongoing study right now, RTOG Foundation study called Keystroke. This is a randomized phase 2. We have it open and enrolling. The endpoint is actually PFS. And the secondary endpoint, of course, is survival. Arm 1 is SBRT given over 2 weeks, according to some of the guidelines we talked about, 40 gray or so over about 2 weeks. And then they get pembrolizumab for 2 years. The other option is to give SBRT alone. And then if they progress, they're allowed to cross over to pembrolizumab. So essentially what this study is going to provide us with is a test of whether upfront SBRT for recurrent disease, locally recurrent, like a regionally recurrent disease, is better than delayed immunotherapy. Sorry, I guess I should be saying delayed immunotherapy in the context of SBRT. So those are a little bit reversed, but it's essentially a test of SBRT with immunotherapy up front, SBRT with delay of immunotherapy later. So in summary, for reirradiation, you want to have at least a 6-month interval minimum from prior radiation, but 2 years may actually be a better cut point, in my opinion. You want to give large margins around gross disease. We generally avoid elective treatment. We aim for 66 gray, or in the case of SBRT, 40 to 44 gray in 5 fractions every other day. We try to reserve SBRT for those cases where we have disease at 3 cm or smaller. Over 3 cm, we're really talking about IMRT with radiosensitization. And multimodality is that, you know, while there is no evidence right now to support reirradiation with immunotherapy, certainly the effectiveness of immunotherapy and its increasing use as an upfront option, first line for some of these patients, really deserves study. And that's why we have the Keynote study open, to try to at least shed some aspect of light on that one particular scenario for using SBRT. Okay, very quickly, I'm going to just spend the last few minutes here talking about postoperative flaps. I would like to point you to these 2 important articles, which were both published by the Gortek group and both published in the Green Journal. And I think the most important one actually is the Gortek consensus, which was a production of Gortek in combination with actually my guidelines committee at HNCIG, the Head and Neck Cancer International Group, which served as the peer referee for the Gortek recommendations. And there's some really good principles that are outlined in the Gortek recommendations. So one thing that's important to know about the Gortek HNCIG recommendations is that consensus was generally kind of low because there is just a lack of knowledge and a lack of good prospective data on how to handle flaps in the postoperative setting. So we're not necessarily talking about reirradiation here. We're just talking about flaps generally and trying to outline some principles for how to handle flaps. And the ones that are marked FR means formal recommendation. Those are the ones where we were actually able to achieve any kind of consensus between the GORTEC and the HNCIG. And you can see here, under flap delineation principles, there's some basic principles here that surgical anatomy is really important, where clips are placed, that the surgeon is able to describe the anatomy of the flap as it lies in a relationship to the normal anatomy, and also that the planning CT should be conducted such that you are aware of early evolution of recurrent tumor, and also to be able to visualize the flap well. Principles of tumor spread, this is probably the most poorly understood area and therefore achieve very little consensus. But there is a recognition that the area of the junction between the flap and the normal tissue probably is at least one of the highest risk areas, and that the dose level to that junction is really critical to maintain. That was really the only consensus we could achieve, because every other proposition had not enough evidence behind it such that an international consensus could be made. On functional outcomes, I think there's more consensus here that radiotherapy does have negative effects both on the fat of the flap, and the bone reconstruction of the flap, as well as the native bone or tissue that surrounds it. And also that the pedicles, that it's important to understand the relationship of the pedicle to the flap, and that the pedicle can be safely radiated, but does not necessarily need to be covered as part of the flap. So those are just some, I think some general principles, which hopefully we'll be able to use as we design further guidelines for this. And then finally, in terms of how we would conduct IMRT over a standing flap, there were some cautionary notes, which is that you have to be very careful with thin flaps because of the risk of atrophy, fibrosis, and potential tissue necrosis or osteoradionecrosis, and that limiting hotspots is very important around thin flaps or areas of the pedicle in order to avoid causing either vascular damage or disruption, as well as damage to the flap surface itself. There is actually a GORTEC atlas that they've tried to put out on free flaps. So this publication goes over the 5 different major kinds of free flaps and the importance of understanding the anatomy as they relate to the flap. I'm really happy that there's a lot of surgeons here who can talk about this more during the panel, but I think there's a very low understanding of flaps in general within the radiation oncology community. And so it's helpful to that we're now starting to look at this more intensively and try to understand and work with our surgical colleagues better. And so the GORTEC publication there, the first one, does outline some atlas principles for how to radiate a flap. And you can see here some of the major principles are that you have to understand where the flap itself lies, where the pedicle is inserting from the flap into the vascularization point, anastomosis, and then also, what the relationship of the flap is to the normal anatomy, such as the soft tissue and bone. And that's why it's very important on your planning CT to use contrast and maybe even get an MRI simulation if you can, because it will really help you to understand the relationship of the flap to the normal anatomy. So again, here's another example from that atlas, just demonstrating a sort of typical layout of a flap and showing you how you can avoid contouring some of the normal anatomy and the pedicle itself. And this is a fibula free flap. And as you can see, so remember, these contours are showing the flap itself. They don't necessarily constitute your CTV, right? So the CTV would be designed to encompass the flap as well as any postoperative areas. But the point of this atlas is that it's important to understand what is flap and what is not flap. One of the issues is that they've actually found that the GORTEC reference contours are poorly accepted and understood within the radiation oncology community. So there was a study done on inter-observer reproducibility with 14 experts, including myself, who delineated flaps from 6 patients over the most 5 common types of head and neck cancer flaps. And what they found was that the dice similarity coefficient, which is a measurement of the concordance between contours, was actually quite low, ranging from 40 to 80%, depending on the type of flap. Showing that there's some lack of reproducibility even among head and neck cancer radiation experts about how to draw these flaps. Last thing I'm going to finish here with is the DHANCA guidelines for resection of the neck. And so when we have local regionally recurrent head and neck cancer, sometimes we're also talking about how to deal with recurrent masses in the neck. And there's actually an atlas to describe how to handle this situation, either in the context of an R0 resection, where you can use kind of a standard margin and standard doses, versus an R1, R2 resection, or the presence of E&E, where there are specific recommendations to expand outwards to cover all the potential anatomic boundaries that are involved with E&E. And if there is any area within the within the DHANCA standard that is ill-defined preoperatively, that area mandatorily should be considered part of the CTV, at least the moderate dose CTV, to include within that as well. So in summary about flaps, an understanding of the surgical procedure that was done and what the resultant flap anatomy is really important. We agree that the highest risk areas are those at the junction of the flap and normal tissue, but also we have to pay attention to areas of R1, R2 resection, and anything that was ill-defined preoperatively should also be considered at highest risk. And I think we can say, based on consensus at least, although there is no prospective data to support this, that lower doses of radiation are justifiable to areas that are considered at lower risk to try to maximize the functional outcomes and lower the risks of flap atrophy, fibrosis, and potential necrosis. And while these two topics are kind of separate, one thing I want to add is that at least at my institution, and I think at many tertiary quaternary care institutions now where we have the ability to do flap reconstruction, we very much lean towards installing flaps for reirradiation, precisely to avoid that situation that I showed you, because we do find that having flap tissue, having well vascularized new tissue within the reirradiation area really does help to minimize the risk of necrosis and fistula in the reirradiation setting. And I think now that we have that capability in the modern era to perform these complex reconstructions, it may really change how we're able to deliver reirradiation more safely. All right, so thank you so much, and look forward to the discussion and questions and exciting panel.
Yeah, thank you so much, Prof. Sure, that was a very informative lecture, and it gives us a lot of insights and new insights. So let's continue to discuss maybe the first panelist, Prof. Bambang. Prof. Bambang, the ENT surgeon. Prof. Bambang, can you unmute yourself? Yes.
Thank you, Dr. Handoko. And first of all, thank you for IROS to invite me join this meeting today. And then thank you, Dr. Professor Young. Nice, informative lecture today. There's because as I know, in my department, the ENT department, still many problem about the head and neck cancer in after the surgical. As you know, in my department, the most patient is first is a nasopharyngeal cancer, and the second is a laryngeal cancer, and then sinus paranasal, and the other like the tongue and the oropharynx, this back. The problem is most of the patient came in the late state, For example, stage 3 or stage 4. This is the problem. This is difficult to treat patient totally because some of the patient refuse of the treatment. Like for example, in the laryngeal cancer, some of the people is refuse of the laryngectomy and then follow the. In my department, I same with your procedure after the total laryngectomy or after the surgical treatment of the head and neck cancer, we follow the radiotherapy or the chemotherapy, depend on the condition of the patient during the operation. And then the other problem is about the, for example, patient with laryngeal cancer, T4, but no metastasis in the lymph nodes. This is still we continue with the selective neck dissection, and then the question is, should we follow the radiotherapy or not, or radiochemotherapy or not? And then this one, no lymph node, but the T is a T4. What's your suggestion? Still after the selective neck dissection, we still follow the radiotherapy, or we wait until the condition of the patient? This is my first question. And the other is, for example, for the since in the tongue cancer, sometimes we do the hemiglossectomy, and then we top the lymph node, but we still selective neck dissection supraomohyoid lymph node. This is still what you suggest. Follow the radiotherapy or follow the radiochemotherapy? Thank you.
Yeah, thank you, Prof. Bambang. So you raised two cases for discussion. So the first one, the T4 laryngeal cancer, T4 and 0 after total laryngectomy, is that correct? With R0 resection?
Yeah.
Do we need to follow it with adjuvant radiotherapy immediately, or chemoradiotherapy, right? So maybe before I ask Prof. So maybe we have a panelist, radiation oncologist here, Dr. Rudiyo. What do you think about that case? What's your opinion if we have a T4 laryngeal cancer and 0 after total laryngectomy with R0 resection? What adjuvant treatment will you consider?
Thank you for the question. In my center, that for the cases, I will just go for the low dose radiotherapy for the 50 gray for the local, but no chemo radiotherapy, I think.
So what is your target? Only the tumor bed?
Yes, the tumor bed only, and then it's tumor bed, correct.
Only tumor bed up to 50 gray in conventional fractionation.
Yes, 4 weeks of that, the latest.
Okay.
Yep.
Okay. When will you consider adding chemotherapy?
If there's a node positive, I think, Prof, we will put chemo radiotherapy. Yes.
Or maybe R1 resection.
Oh, of course, yes. R1 or R.
Okay. Okay. Thank you, Dr. Rudiyo. Prof, what's your opinion on this?
Yeah, so the we had some NCDB, National Cancer Database analysis, that showed that for T4 larynx cancer, post-operative radiation therapy should be given. But there is not very clear evidence to support the addition of chemotherapy. So I agree with the answer that was given. We would not usually give chemotherapy unless there was some additional indication. And so obviously, if it's a positive margin, then we think chemotherapy should be given because there's survival advantage proven with that from the old RTOG study. And then also for extracapsular extension of any lymph node, we will give chemotherapy with the radiation. If the patient has had a good neck dissection, and by good neck dissection, I mean levels 2 to 4 on both sides of the larynx, then I think the neck has been treated appropriately, and if it's N0, we will not radiate further. And even if it is N1 with one lymph node, we will not radiate further to the neck because it has been electively dissected. But if there is more than one lymph node that was found, or if there is extracapillary extension in any lymph node, or if the lymph node is very large, meaning over 3 centimeters in size, meaning it's now N2A, then we're going to consider postoperative radiation to that neck. But again, we would not still give chemo to the patient unless it's extranodal extension in the neck, or some concern about the ability to resect all the nodes. Now, the other thing to add, which surgeons don't like to hear, is that after the surgery, we will get the contrast CT enhanced planning scan. And sometimes, you know, it's not necessarily the fault of the surgery, but sometimes on that planning scan, we see regrowth of tumor, or we see lymph nodes that were not dissected that are very suspicious. And then in that case, we convert to a definitive chemoradiation treatment to treat that residual gross disease that was not removed or which has arisen since the surgery. And so it's always kind of annoying to my surgeons because we sometimes about, you know, I would say, you know, the data from Princess Margaret shows, especially for advanced stage oral tongue cancers, the rate can be as high as 15% that you find residual or recurrent disease at the time of the radiation simulation. Then we're going to add chemotherapy for that situation as well.
Okay, Prof. How about the radiation dose you will
yes, yes. No, well, I mean, I think you were saying 50 gray in 4 weeks. Is that right?
No, I mean, like, we are starting the radiation courses 4 weeks after the surgery.
Yes.
Yes, yes. And then the dose for the T4 and the R0 resection is going to be 50 gray maximum.
50 gray and 25.
40, yeah, in 25 for the R0
Oh,
resection.
well, I mean, you know, in the US, I think the standard post-op dose for whatever reason is 60 gray and 30 fractions. You know, certainly some people may give 57 because the, you know, the MD Anderson series showed, you know, that you could get 57.6. But yeah, so, you know, just the conventional standard in the US is 60 and 30 gray to the primary tumor bed. Now, I agree with you. If we're going out to the elective nodal regions where the risk is very low, we would probably be talking more like 15, 25.
So you are taking that as a high risk region, because even though it's the R0 resection of you?
Well, 60 gray in the United States, 60 gray and 30 fractions is considered standard risk, like regular risk. For high risk disease, if we have like a, you know, close positive margin, or we have some extranodal extension, we're going to give 66. But I don't think 50, I don't think 50 and 25 is necessarily like totally wrong. You know, I will just say maybe in the United States that would be considered a little low, because the MD Anderson study showed that, you know, they originally started their post-op study at 54, and they actually had to raise it up to 57 because they were seeing too many failures. So because of that, the United States, but that was being given in 1.8 gray. So, you know, there's some controversy there, but because of that, I think the United States is more interested in 60 and 30 for kind of standard risk. Now, you know, the thing is, the way you design the volumes with IMRT, it's like just amazing. So you don't have to put 60 and 30 all over the place, right? You can put 60 just in the areas like we were sort of talking about. I think this is going to evolve with flaps, you know, whether the entire flap has to be treated to 60. That's kind of the tradition, but I think that there is some heterogeneity of opinion developing there where people believe that maybe we don't need to treat the entirety of the flap to 60 now. That's an area of research.
Because there's going to be two dose levels. What you're talking about, like 150 and then the other is 60?
Yeah, we usually, I mean, because we're giving it IMRT SIB in 30 fractions, we give 60 and 54 usually, but you know, I mean, it's just the standard in the US because of all the protocols have been giving 60 and 30. And I will say one thing is, like, especially for recurrent disease, this doesn't sound like it's necessarily recurrent disease, but especially recurrent disease, the Myriad Collective showed that you really have to give 60 to 66. So definitely for that setting, we're going to be giving 60 at least.
Okay.
Okay, thank you, Prof. and Dr. Rudiyo. And then the second case from Prof. Bambang, it's oral cancer, oral tongue, post-hemiglossectomy, right? Is that R0 or R1 resection, Prof. Bambang?
Yeah. Supra-omohyoid neck resection.
Okay. With N0 or N1?
N0.
N0.
N1. Yeah.
Oh, N1.
Good question. N1 or N0?
Okay. The T stage.
Yeah.
So the
tumor is T2 or T3.
Okay, the T2 or T3 with N0 or N1, post-op hemiglossectomy with supra-omohyoid neck dissection with complete resection, so R0 resection. Do we need to continue with radiation? Okay, maybe Dr. Rudiyo, what do you think? Will you give adjuvant?
Okay, for T2 and T3 tongue cancer, we do hemiglossectomy is very hard. It's going to be a problem for the functional later, right? For the functional for this patient, yeah. I don't think for the T3 we can. It's one of the best choice to do the operation. It's better to do the chemo radiotherapy for this patient.
Yeah, the case is the patient has been resected. Let's limit it. Let's say it's a T2 N1 disease. Already received
with the
surgery.
R0 resection.
Yes, R0 resection. T2 N1. Will you continue with adjuvant?
No, I think for this patient it's better to do the board meeting and choose chemo radiotherapy. I think, other than surgery for this, because the patient going to be probably the swallowing later and the rest of his life, I think.
Oh, okay.
Yeah. What do you think, Prof. Su?
Okay, that's your suggestion. But if the patient has been resected by Prof. Bambang, will you continue with adjuvant radiation?
For the N1 T3 N1, yeah, I will follow the adjuvant chemo radiotherapy. Yes.
You will add chemo also, even with R0 resection.
Yes, and then if the tumor cross the line, I'm going to give prophylactic for the contralateral node, and then I will give 60 gray minimum for the ipsilateral node.
Okay, so you will give 60, 40, 54 in 30 fraction?
Yes, in 30 fraction, 33 fraction. 60, yes, no, I want to give 60, yes, in 30 fraction, correct.
Okay, thank you, Dr. Rudiyo.
So,
so what's your opinion, Prof. Su?
So this is a recurrent patient or this is just a new patient?
No, the new patient, T2
new patient, and it's oral tongue, not basic tongue, oral tongue.
Yes, oral tongue.
Yeah. So this is actually the most difficult, I think. I think these patients are the most difficult because actually, if the patient has had a good surgery for T2N1, we do not have absolute indication for additional treatment. They may be eligible to just have observation. And so for a very young patient, this is a very difficult decision because their recurrence rate is going to be something like 15 to 25%. And so with this kind of patient, I have to sit down and talk to them a lot about, the risk is somewhere between 15 and 25%. Is that acceptable to you? And then the morbidity, like Dr. Rudiyo was saying, of combined surgery and radiation is quite high in a young patient. So we're going to have to talk about that. So, I would say that if you took our overall population of T2N1, probably we radiated more of them than not, but it is certainly valid not to give further treatment. Now that is assuming there's no other bad features. So there's no, collection of features. In the original MD Anderson postoperative studies, they found that if you have four bad features, PNI, LVI, poor differentiation, you know, all the close margin, all these minor features. If you have 4, it's equivalent to extranodal extension. So if the patient has many features that are very poor, we're gonna kind of think about that, like that it's almost like an E&E case, right? Or if the patient has extranodal extension or positive margins, obviously they have to be radiated. So that's kind of how we talk about it with the patient. And one thing to also think about is that for oral tongue cancer like this, if we are very concerned about the margin, we may try to dose escalate there. So sometimes we will give the external beam for 50 gray and then give brachytherapy implant to the surgical bed to try to really dose escalate that margin and decrease the morbidity of the treatment.
Okay, Prof. So if the patient has not been resected with clinical T2N1, would you advocate surgery first or chemoradiation if patient agree with both?
Yeah, so that is a good question. The problem is that the chemoradiation results for oral tongue cancer have been kind of mixed. So some institutions have reported very good result, but many institutions have reported a less good result. So I would say, you know, in the United States, even though there's some controversy about this, you know, whether you should give preoperative radiation, whether you should give definitive radiation, whether you should give postoperative radiation, generally speaking, the standard of care has been postoperative radiation. And part of that is because for a T2N1 case, like I said, you may be able to get away with surgery alone if the patient had a very good surgery, excellent margins, over 5 millimeter, one small node, no bad features. That patient may not need any further treatment, and that, of course, will be the least morbid. So, you know, that's why I think in general we're going to prefer surgery there.
Okay.
Also, definitive chemoradiation for oral tongue cancer, you need to get to like 70 gray. And delivering 70 gray into the oral cavity is extremely damaging to the mandible. So unless we have a good way to, you know, protect the mandible, which you can try to do with spacers, or, you know, again, we can give 50 and then give a brachytherapy implant, which we can do also. You know, you're going to have to think about that. It's a technical problem, right? To give so much dose to the tongue. And especially if it's the, you know, if it's going very deep into the tongue or across the midline, you're going to have a lot of dosage going to the mouth. So, you know, if the patient is, you know, able to have surgery, or if the patient is kind of on the younger side, I think surgery, you know, may give you a chance for less morbidity overall from the total package.
Yeah. Okay. Thank you, Prof. So
Can I,
maybe
Dr. Handoko, can I continue to ask question for this kind of patient to Prof. If let's say that this patient gonna have radiotherapy that is called T2N1 cases for the tongue cancer, and then if you give the radiotherapy and you continue with the brachytherapy, interstitial brachytherapy with the N1, how do you manage for the courses?
Yeah, that's a great question. Actually, we just did this for somebody. So for that situation, what we do is we give 50 gray initial plan, or maybe like 54 gray initial plan, and then we come outside the mouth and we are boosting to the gross disease in the neck, continuing there for a second plan, and then we take them for the brachy implant to the tongue.
Okay,
Yeah.
because we also have one case for that. And what's the dose for the brachytherapy you're giving?
Yeah, we usually give
for the
like,
booster.
yeah, well, so we do HDR brachytherapy. We don't have low dose rate for head and neck brachy anymore. So we give usually 16 gray. But we can give maybe 20 gray, and usually we give that over 4 or 5 days. Inpatient, we have the patient inside with the catheters and give it every day.
Yeah. Okay, Prof. So maybe we continue first with Dr. Diani. Dr. Diani is the surgical oncologist, but she has a lot of head and neck cases too. Please, Dr. Diani.
Thank you, Dr. Handoko. First, thank you for IROS for inviting me for this event this morning. And then thank you for Prof. Yom for very nice lecture today. In my division, oncology division, Department of Surgery, we have mostly case of squamous cell carcinoma of the tongue. It's more than 50%. The patient come with the locally advanced stage. And then the second one is buccal side and also maxillary and mandible. And then for the patient with a locally advanced, sometimes we give neoadjuvant chemotherapy first before surgery. And then we have to evaluate the response. If the response is good, we continued with surgery, and then we can give radiation therapy with for the patient. Based on our research, the survival is not quite good. 1 year overall survival for locally advanced oral cancer is 54%, and then 2 years overall survival is 21%. I have two questions for Prof. Yom according to our case. For squamous cell carcinoma of a maxillary region, we have some patient with maxillary squamous cell carcinoma of maxillary region T3. What kind of radiation would you give? Local radiation only or local regional radiation with N0? And then the second one, what is the best combination choice for radiation and unresectable oral cancer, especially in cases where we already give neoadjuvant chemotherapy, but the result was progressive disease? I mean, would you give combination with chemotherapy or targeted therapy? Thank you.
Yeah, thank you. So please, Prof. Yom.
So you're saying T3N0 maxillary sinus
Yes,
squamous cancer,
for
and that patient was resected or not resected initially?
After white excision and also upper neck section, supraomoyoid.
Yeah.
T3.
Right. So T3N0 is an interesting, again, very difficult case because there's an MD Anderson analysis, which was done by actually Dr. Kian, who came from Indonesia, to MD Anderson for a long time. And Dr. Kian, he found that if you have a maxillary sinus cancer that is T3 or T4, or if you have a maxillary sinus cancer that is squamous cell carcinoma histology, you should give postoperative radiation, and it will improve the outcome and survival. And also that the nodal area that is at highest risk is level 1 and level 2A. So we are going to, for a T3N0, especially squamous type, we're going to radiate that post-op 60 gray and 30 fractions. And then we're going to radiate the neck at least 50 gray. But if there's a lymph node that was found, then we radiate 60 gray. And we must include 1B and 2A nodal regions at a minimum. But if there is a positive node that was found in 1B or 2A, then we're going to radiate possibly 1A and possibly 2B and level 3 if the node is in 2A. So we kind of expand outward if there's some lymph node found. But yeah, so for T3N0 squamous cancer, I think you should deliver postoperative radiation. And then the other thing to talk about, of course, is that, in the United States now, with some of these cancers, they're giving neoadjuvant chemotherapy before the surgery. That's a very controversial practice. At least the way that the people argue for it, they say that if the patient responds to the neoadjuvant chemotherapy, then they have a better prognosis and you should put them through the surgery and the radiation. But if the patient is doing badly during the neoadjuvant chemotherapy, there was no hope anyway. Well, you know, that's kind of controversial because a lot of our surgeons feel like there's a window of resectability, and if you give chemotherapy and the patient is progressing, then you lost the window of resectability, and you know, maybe it was worse for the patient. So we don't have any comparative study on that yet, but it's a very, very controversial thing. But there are some places that are doing that for maxillary sinus cancer.
I know it's for locally advanced when we give neoadjuvant is a controversy, but because it's
Yeah,
depends.
because it's like a chicken and an egg thing, right? Like you say, like, okay, well, I gave the neoadjuvant chemo and then the patient progressed, and you say, well, they would have done badly anyway. I mean, or maybe you don't believe that, and you think that if we had resected the patient properly when they were still resectable, they would be doing better. It's unknown. That is an unknown question right now, because the role of neoadjuvant chemotherapy has not yet been shown to be of clear benefit in patients' outcomes overall. But the argument for it at certain institutions, not mine, but at certain institutions that are doing that, is that they think it selects the patients who are going to do better, and then it's more humane to subject those patients to the intensive treatment, right? So it's more of a selection principle than really like changing their outcome.
Okay, thank you.
Yeah, and then for your patient who's progressing on neoadjuvant chemo, that's a very bad situation. So you can, you know, argue that a lot of different ways. You can say because they're progressing on neoadjuvant chemo, kind of no hope, and maybe you should just, you know, kind of treat them more palliatively, and probably if you can, maybe you intensify the chemotherapy or you put them on chemoimmunotherapy, something like that. The other way you can go is you can try to give them really high dose radiation therapy, such as 74 gray, which I will give. But the problem is that if the disease is progressing very, very rapidly, you cannot plan the radiation fast enough to stay ahead of it. And it's just going to grow outside your radiation field, right? So the pace is very important. If I feel like the situation is too unstable, I don't think it's a good idea to start radiation. So I will ask the medical oncologist to try to intensify the treatment or change the treatment to get to some stable state where we can deliver very high dose radiation. But we will increase the dose to 74 gray in that situation because the patient has already shown they're extremely resistant if they're progressing through chemo.
Okay, thank you, Prof.
Okay, thank you, Dr. Diani Aproso. So now next, we have Dr. Parintosa, our plastic surgeon. Maybe it's very interesting because it's more and more patients will have flap now. Please, Dr. Parintosa. Please unmute. You have not unmute yourself.
Okay, thank you, Dr. Handoko. Okay, good morning and good evening for Prof. Yom. Thank you for the IROS for inviting me in this prestigious meeting. And also thank you to Prof. Yom for the fantastic presentation and also the GORTEC guidelines that's explain about our field. There's the free flap surgery. I'm Parintosa. I'm a plastic surgeon, and then my field in our hospital is about the free flap reconstruction. And for head and neck reconstruction, we often use a radioforearm, ALT free flap, and also for bone we use the fibular flap. Not a lot of free flap we perform. I mean the model, the flap, but I think more than 300 free flap we work and we perform, and then with the any problem, some problem, but in our experience, the free flap surgery after the tumor removal is not quite have a problem. But the problem started after the patient receive the radiotherapy. We know that the radiotherapy make flap become not the good condition. I mean the for the skin flap that becomes fibrosis and then not pliable, and then for the bone flap, it is a risk for the osteoradionecrosis. And then I think the question we can see at the chat box. My colleagues also asked about it. And then in the problem of our patient is about the wound after the radiation, especially for the radiation after reconstruction. And then the problem is sometimes patient cannot receive the radiation because of the wound and not completely heal. So I want to ask about and need the comment for Prof. Yom about the condition for the patient before receive the next radiation. Why? Because sometimes you explain that the time for the radiation is more than 6 months. Is right? Yes, and then sometime over than 6 months, the wound is not completely well. So the patient back to our clinic to treat the wound, but very difficult to treat the radiated wound. So is it okay if our colleagues from the radio-oncology therapy give the patient radiotherapy with the not completely well wound? Because in my perspective, we can reconstruct the large wound after the radiation with another free flap with the good and better condition, so patient can have a good condition for the daily activity. I think this is my question for the wound to Prof. Yom. Thank you.
Yeah, thank you, Dr. Rocha. So, Prof, what do you think if the plastic surgeon has put on the flap after the surgery, but it's not completely healed, with patient have high risk features requiring adjuvant radiation? What is the strategy?
Yeah, we usually try to let the flap heal. It's really important not to radiate too soon on that flap because you can cause so many problems. And I know sometimes you get like the infection and the bad flap problems and stuff like that, but we really try to give at least like a month for the flap to reduce the edema and make sure that the vascular supply is good. And then if the flap is really still in bad shape, even after a month or month and a half, then unfortunately we do have to radiate the flap. And it may be that, eventually the flap will be removed and we have to put another one or something like that. But after like 6 weeks or 8 weeks, I think the risk is getting too high to wait any longer. But we do really try to not radiate an open wound if it's possible. Now, one exception here is that sometimes the open wound is actually tumor. So if we talk to the surgeon and that area of the non-healing wound is in the area where there was positive margin or inability to resect tumor, then we actually do radiate in that circumstance because we believe it's unresected tumor that's causing it not to heal. So you have to kind of understand why the flap is not healing well. But yeah, it's a big problem in post-op setting because if once you radiate the open wound, it's unlikely that it's ever going to get better. So we have to just decide, when does the cancer treatment take priority, and it's worth it to sacrifice the flap, but that's a hard decision.
Yeah, and I think Dr. Ocha also asked, and How about after radiation, adjuvant radiation, and then after that do the reconstruction and put on the flap? Is that a viable option too? So, Professor, Dr. Ocha also.
You're asking me? Yeah.
Yes.
Oh, okay. It's possible, but I will say some of our plastic surgeons are very nervous because they feel that it's very difficult to put a flap on a radiated area.
Yes.
They think that it's very difficult to get it to heal properly. So also after the area has been radiated, it's very hard for them to find a good vascular supply.
Yeah.
Is that would you agree with that?
Yes. Yes, I agree. It's very difficult. Sometimes we must going far from the head and neck area to the neck or to the mammary internal to have a good vascularization for the recipient vessels. Yes.
Okay. Dr. Rocha, do you have any more comments?
No, I think no. Thank you, Prof. Young.
Thank you, Dr. Rocha. So I think we have still a lot of questions in the QA box. Let us address some of them have been addressed by Prof. Shu. The next one from Dr. Julie regarding the tips to deal with oral mucositis, odynophagia, xerostomia after chemo RT, especially I think in the case of reirradiation. How is the strategy, Professor?
Yeah, so these are difficult problems. And then what you see in reirradiation, which I think is very interesting and different pattern, is that the mucositis will happen much earlier. So usually with first time radiation, we don't see very severe mucositis until the 3rd or 4th week. But with reirradiation, if you are radiating some important part of the oral cavity or the pharynx, you will see the mucositis happening in the 1st or 2nd week very frequently. So I try to warn the patients about that it will be quick, that they will start to feel it. And of course, it's related to the size of the area that you are reirradiating. When you reirradiate larger area, it's going to be a much more severe impact on the patient. So for these kind of patients, we almost never put feeding tube up front in our patients before radiation. Our policy is reactive. By reactive, I mean that we watch the patient, and if the patient is unable to maintain their body weight or their hydration, 10% loss of body weight or need for constant intravenous hydration, with loss of electrolyte status, then we will put the feeding tube, right? So it's a reactive policy rather than proactive policy or prophylactic policy. But there, for patients who are getting very large doses of radiation to the oral cavity, and for patients who are getting very significant reirradiation and their performance status is low, then we will put a prophylactic feeding tube in place before we start to manage that. We're anticipating they're going to have a problem. And for patients who've already lost over 20% of body weight, we put a feeding tube up front. But again, it's exceptional for us to do that. And then, with mucositis, we're using, like, I think what everybody is considering standard. The oral hygiene is actually very important. So we do antibacterial and antifungal rinse very frequently. We also try to give them special mouthwash with like some anesthetic in it. We have a topical anesthetic, and then also lidocaine, to help them, because actually managing the pain is an important part of the component, because if they manage the pain, then they're going to be less inflamed and less irritated. So really good oral hygiene. We make them rinse their mouth with baking soda 8 times a day. And then, like I said, really controlling the bacterial and fungal infection. And then we also have them go to the dentist, and we clear out any kind of dental infection prior to starting the treatment. And so with those things, you can prevent the very worst side effects. But it's going to be inevitable, especially in reirradiation, that you're going to get this mucositis, right? So then you have to manage it with pain control and feeding support. And there are some experimental therapies that people are using, such as laser treatment, which has been shown maybe to increase the, to decrease the severity of the mucositis. And then some people claim that by using different kinds of amino acid, you know, or glutamine type of thing in your mouth. So we don't use the laser because frankly, it's too work intensive. You have to give it 3 times a week to these focused areas, and it requires about 30 minutes. It's just too much for patients. But we do use glutamine supplementation. We give a special high dose formula, and then we try to encourage a high protein diet because that really helps with healing from the mucositis. And then xerostomia, I think the other question was like xerostomia and something else, right?
Odinophagia.
Oh, yeah. Well, odinophagia kind of goes with, you know, we have swallowing therapy. So the patients all go for their swallowing therapy and trying to help manage that with the pain of the mucositis. The xerostomia we manage with actually we give pilocarpine or other parasympathetic stimulation to improve the function of the saliva glands. And then we also are doing parotid and submandibular gland sparing technique with the IMRT. And then we also, again, really emphasize the moisturization. So we actually encourage all our patients to get a humidifier so that they are breathing humidified air to keep it moist, because actually the dryness causes greater injury and greater risk of infection, both to the mucosa and to the teeth. So it's very important, like, to keep the principles of cleanliness, but also moisturization. And then we have the patients use special lozenges, like saliva lozenges with, you know, we have a couple brands of that, and we give them a saliva substitute to coat their mouth. One very effective trick that we used a lot for some of our patients that they like a lot is coconut oil. So they put the coconut oil in their mouth, and it creates a kind of a viscous surface and kind of melt like slick. And that can actually make them feel much better and keep it from cracking. So olive oil or coconut oil or any high quality, like very good oil like that. And we try to encourage them to put that in their food also, so that it's a very oily thing and keeps the mouth more moist at night.
Okay, thank you, Prof. And then next question is from Dr. Mo. Optimal time to start post-op radiotherapy if the wound is well healed?
Yes, so optimal time is 6 weeks. So the only data we have, again, comes from Dr. Ong's study, MD Anderson studies, looking at the timing of postoperative therapy. And for those patients that have R1, R2 resection or extranodal extension, you must start within 6 weeks. But then for patients who are kind of routine risk, less risk, you can start up to 8 weeks later. But ideally, you would like to start before 6 weeks.
Okay, thank you. And
that's usually just barely enough time for a good flap to heal. It takes about 6 weeks just for the flap to be in some, you know, decent stage of healing.
Yeah, okay. And if you start after 12 weeks, then how is the impact on the overall survival?
Yeah, so the studies of that are not clear. After 12 weeks, obviously, it's very detrimental to the outcome. But there is some evidence actually that perhaps if you add chemotherapy, you can mitigate some of the impact of the extreme delay. But I have to say, if you got to 12 or 14 weeks with the patient, it's really a question whether maybe you should even radiate at all, because if the surgery went really, really well and they still have not recurred at 12 or 16 weeks, it's a question how much the radiation is really helping them. So in a case that's very, very low risk, after 16 weeks, after 4 months or 6 months for sure, we really question whether you should even radiate. But of course, in a high risk patient or intermediate risk patient where you still feel there's substantial risk, we will consider chemo at that point, and very careful attention to the design of the radiation such that we are maybe giving 66 gray to the high risk areas.
Okay, thank
to
you,
try
Prof.
to mitigate for the delay. Yeah.
And then another question from Dr. Endang. Do you perform prophylactic tracheostomy in advanced oral tongue, maybe locally advanced, so T4 attaching to the base of tongue maybe to keep the airway open?
Yes. Frequently my surgeons will perform a tracheostomy. And then the question is, should they leave the tracheostomy in there when the radiation is being given? And that's kind of, individual judgment question. Really probably depends on the patient anatomy, because if you think that the area that will be receiving the high dose radiation may swell up with the radiation and cause some airway problem, then we will leave the tracheostomy in there during the radiation, even though it's very uncomfortable. Usually, almost always, we try to get the tracheostomy out before we start the radiation. The reason for this is that radiating the tracheostomy site, it may cause some problems with healing of that site later. So if it's possible to get the tracheostomy out, then we would like to get it out. But if there's going to be risk because the area we're radiating could swell up and close, then we got to leave the tracheostomy in. And then also, if the tracheostomy was done any area near the cancer and there's a possibility that there's cancer contaminating the trach, then we're going to leave it in and we're going to radiate really hard over the trach site because we need to make sure that that area is covered well, right? Or I suppose you could try to take the trach out, but then you have to mark the tracheostomy site well, and you have to cover that in the high dosage if there's any possibility. So for instance, like this might happen with like a larynx or hypopharynx cancer, where you actually are traching through tumor. In those cases, we have to make sure that the high dose radiation is covering that whole trach site and also out to the skin, because that is a essentially like, positive margin in some way.
Okay, thank you, Prof. And then the next question from Dr. Julie. There's an emerging idea to do hypofraction, external radiation combined with interstitial brachytherapy. What do you think about this, Prof.
I think we're talking about post-operative setting. So hypofractionated radiation for head and neck has really been done the most in the intact non-operative setting. So for instance, like the Christie Manchester in England or places like that, some of the Canadian experience was with hypofractionated radiation, but that was for patients that did not have surgery. In the surgery, post-operative surgical setting, it's very rare to do hypofractionation. Where we see it the most is in skin cancer. So post-operatively for skin cancer, the Trans-Tasmanian Australian group does 48 and 20 gray. And they did that for melanoma, but they also do it for other types of skin cancers. And then some people believe that you can use that fractionation schedule for salivary gland as well. The rationale is that because you're only treating usually one lateral side and it's not going into the pharynx, that you can get away with this hypofractionation, 48 and 20. But like for oral tongue or for other things like larynx, hypopharynx, things like that, we have not used hypofractionation for that kind of situation. Oral tongue is, something people are thinking about. There's some phase 1 studies now ongoing to look at hypofractionation for oral tongue, but and potentially you could use brachy with it, but we haven't proven that that is safe. And the big concern with doing it on oral tongue or larynx hypofractionation is that your functional situation with the mandible or with the function of the pharynx, the esophageal reconstruction after laryngectomy could be a real problem with the swallowing function. So we don't usually use hypofractionation yet outside of the skin cancer or the salivary gland cancer post-operatively. Again, for intact cancer, like brand new diagnosis of oropharyngeal, the Manchester Christie group has used some hypofractionation, but they only really do that in elderly or poor performance status patients. And they have not done it with chemo. So, you know, we're still pretty cautious about hypofractionation, especially in combination with chemotherapy.
Okay, thank you, Professor. But about that, what do you think with the emergent more and more proton facility? Do you think hypofractionation can become more common? Or
Yeah, I don't know. I mean, they haven't done that study yet. So right now, protons is not even really, you know, strongly indicated for head and neck cancer yet. It's not what most of the head and neck cancer patients are receiving. So until proton therapy shows that, you know, it can be competitive, you know, it's still, I think there's still a lot of software problems to work out with proton therapy. The modeling of the dosimetry is not as good as it is with IMRT. So until we solve some of these technical issues, I think it's going to be a little bit, you know, unknown, like how we're going to do that with proton therapy. The other, you know, the other thing to think about with proton therapy is that proton therapy is very sensitive to changes in air and fluid level. And in the head and neck region, you often have small changes in the transition between airspace and tissue space, especially sinus cancers or the oral cavity. And that transition from air to tissue or air or fluid to air is really, really, proton therapy is very, very sensitive to that. And so, you know, you have to have really robust modeling and software to properly understand that. And so I think, you know, there's just a lot of technical development that has to be done because the head and neck region is pretty complex. Again, for intact tumors like maybe nasopharynx and potentially oropharynx, you know, it may be a little more stable. And so maybe proton therapy will do better there. But even right now, the current trials that are going on with proton therapy for those cancers are all conventional fractionation still right now.
okay, thank you, Professor. And then I think one last question is right on time from Dr. Julius. In our institution, it is uncommon to conjure the carotid artery. I think yes, for the first time radiation, we did not conjure the carotid artery, so we do not have the dose from previous radiation. What do you suggest to limit the risk of carotid blowout during re-radiation?
Yeah, I don't conjure the carotid artery either. That's okay. We actually, like when we developed the Astro, you know, minimum contouring guidelines, you know, as part of the TG263, we actually had a debate and we decided not to put carotid artery there because there is no dose constraint for carotid artery. And, you know, you don't know, like, is it, I mean, we don't even know whether it's a parallel or serial organ for one thing. Although, you know, you would suspect that maximum dose will be more important, but we don't actually know, like, because you can contour this much of the carotid artery and contour this much of the carotid artery. So there is no DVH that we can specify, right? That's one problem. So most people have just gone with maximum dose on the principle that maximum dose could cause some defect in the artery. And I think that's kind of sensible, but I don't contour it either. What I do is actually I get the plan and then I just look at the plan and I see if we are having high dosage into parts of the carotid artery. I take that back. I sometimes have contoured the carotid. Like for instance, if I had a shoulder sarcoma and we were going to be coming really, really close. So I contoured the carotid artery and the brachial plexus for that case. But, you know, generally speaking, I don't really contour the carotid artery. I look at the plan itself. And the key is that you don't want to have over 100% of your dose going onto the carotid artery. You should keep it cool. That can be really difficult because sometimes, so that's where this encasement thing comes in, right? If the carotid artery, if the tumor is covering 180% of the carotid artery, right? You have a much higher chance that you're not going to have the maximum dose hitting the carotid. But if the tumor is 360 degrees surrounding it, the chances that the highest dose is going to be in the center on the carotid artery. So I think that's why so many of the guidelines talk about like it's acceptable to radiate 180, but it's not acceptable to radiate 360, because I think really what's happening there is you're seeing effects because of the hot spot going to the center, to the carotid. So I'm not worried so much about, you know, the level of encasement, 180 or 360. I'm more worried about our ability dosimetrically to carve the hotspot out of the carotid. And I don't allow more than 100% to any part of the carotid artery on the plan when I look at it. And I try to, if it's at all possible, I try to really minimize the volume of carotid artery that we're including in the tumor volume. So that's why it's much nicer, you know, to have less encasement, because you can do that better dosimetrically. But you know, nowadays with IMRT, you can do a lot. I don't think you necessarily need to contour the carotid artery on any routine case where, you know, your dosage is going to be just kind of average. But if you're going to any high dosage, like, you know, 66 gray, 70 gray, or where your cumulative dose is going to be higher than 120 on the carotid, then you probably should look at the plan pretty carefully.
Okay, thank you very much, Prof. Yom. That's a very practical suggestion for us. And I think that's all the questions have been answered. It's right on time. So yeah, thank you very much. And thank you also for all the participation. We have international participants also too, from Bangladesh, Myanmar, Philippines, Singapore,
wonderful.
Cambodia. Yeah, even
That's
though
so great.
yeah, thank you.
Well, I'm sorry I can't meet you all in person. Maybe someday we will.
Yeah.
And in the meanwhile, you know, I encourage you, please reach out to me, and don't be shy, because, you know, like I said, you know, we're really trying to continue the international collaboration and communications.
Yeah, okay, sure, Prof. Yom. We are very hopeful for continued collaboration. And maybe Prof. Tati, do you have any closing remark, Prof. Tati?
Yeah, thank you very much, Professor Su. That really very interesting topic, and very tight discussion happened already, because it's our daily problem in our country, and especially as it is mentioned by several speakers, that our case mostly is the local or locally advanced cases. So it's not easy to yeah. And so thank you also to all the panelists. It's very interesting discussion I heard, and hopefully it will bring us a lot of benefit. It's finally is how can we give the best for the patient. And for what you mentioned, we here, Professor Su, we have two regional society, the so-called the Sp.Rad. Sp.Rad consists of Southeast Asia. That's why we have a lot of friends from our region coming to this meeting, because we distribute our flyer to all our member to all the member countries from the Sp.Rad, as well as for FARO. So FARO consists of 12 countries, member countries. So if Sp.Rad only Southeast Asia, FARO also include the Japan, China, and Korea, and also the Bangladesh, India, Pakistan, and Bangladesh, India, Pakistan. So FARO is more wide. We have more members from FARO. I used to be the president from both, as well as Sp.Rad as well as in FARO. So it will be very interesting if we can make international collaboration, as also we do with some friends, with Kenneth Hu, for example. So when we have some meeting, maybe we will contact you and really want to invite you to come. So thank you very much, Professor Su. But also friends here, we have from surgical oncologists, with also from the plastic surgeon and from ENT. So Professor Su opened her hand to be do collaboration with all of us. So thank you very much, Professor Su. Thank you very much.
Yeah, thank you, Prof. Tati. Thank you, Prof. Su. It's evening at your time. We are very glad and we are honored for you to be here. And thank you also to Prof. Bambang, Dr. Parintosa, Dr. Diani, Dr. Rudiyo, and also Dr. Ben. Dr. Ben, I'm sorry, the time is limited. So yeah, okay.
Yes,
So
yes,
thank you.
I really appreciate those comments. It's very important because, you know, we really believe the future of head and neck cancer is multidisciplinary. And, you know, it's becoming more advanced in surgery, in medical oncology, also radiation. And it's very important we communicate across all the disciplines so we give the best combination, not just the best treatment of one thing, but the best combination. And that is, you know, very complicated. So the communication is very, very important among the groups, you know, cordial and very professional communication is really the key to a good team.
Yeah.
Yes, thank you very much. And thank you for all the attendees that have participated and you stay until the very last moment. Thank you so much. And we will see you later again next time in the next IROS CME webinar.
Thank you.
Thank you.
Thank you, Prof. Su.
Thank you,
Prof. Tati,
Dr.
Prof. Bambang,
Dr. Mayang
Dr.
and Dr.
Diani.
Thank you.
Bye.